Hi, my name is Mai. I'm a PhD student at the University of Sydney. My project is on adverse drug reactions or events, or ADRs and ADEs, reported in frail older people related to their heart failure or HF treatments. HF is a hot topic because it's on the rise with most people living less than 5 years after diagnoses, and during that time often end up in hospital. 1 in 10 people in hospital are there because of HF, and half of them are people over 75 who typically have more medical issues, medicines, and their cumulative deficits make them more vulnerable to frailty. We registered our systematic review in Prospero and conducted it according to the PRISMA 2020 checklist and validated our search strategy with the PRESS checklist before doing a literature search in 8 databases, registries, and citations. We applied eligibility criteria to studies that included HF patients over 65, taking guideline-directed medicines, identified as frail using objective frailty measures, and reported ADRs and ADEs. We found about 2,400 studies and 2 reviewers screened 1,600 studies with an inter-rater reliability of Cohen's kappa 0.88. 5 studies met inclusion criteria. 2 were RCTs with a total of 15,000 participants, and 3 were cohort studies with about 1,600. We applied the Cochrane risk of bias assessment to these studies, and a second reviewer validated 20% of the studies included. We weren't surprised, and most commonly reported outcomes, or severe ADEs, were death and hospital admissions. In the RCTs, frailty index scores for each outcome showed increased risk for patients taking spironolactone and also for sacubitril valsartan. In both these studies, these forest plots show a dose-response relationship trend of increased risk of hospitalization and death with increasing frailty index scores. This is as high as double the risk of mortality in sacubitril valsartan and 4-fold increase in hospitalization for spironolactone. But frailty had no effect on treatment effect, and the p-values for interaction was not statistically significant. In the cohort studies, 4 classes of drugs applying the frailty phenotype criteria also showed that compared to robust patients, frail patients had a higher risk of adverse effects, such as falls, dyspnea, tiredness, nausea, and of course, hospitalization and death. In one study by Eckerstad, Naranjo and Hallis criteria were applied to evaluate ADRs, in which digoxin was identified as possibly avoidable with a Naranjo score of 5 and 6 for those 2 events. We found ADRs and ADEs were not often reported for well-defined frail older populations, and risk of severe ADRs and ADEs in older adults increases with increasing frailty. So our next step is to explore adverse drug withdrawal effects of HF treatments to inform prescribing decisions. Thank you.